Good evening, everyone, and welcome. I, Dr. Sita Ramamurthy Pal, the chairperson of the Genetics and Fetal Medicine Committee, Fogsi, welcomes one and all to this 249th episode of Gyan Pravah, the podcast series. The Gyan Pravah, which actually means the flow of knowledge, has actually started flowing from 31st of Jan, and it is flowing every day at 8 p.m. with different speakers of different capacities in their own right, or stalwarts and experts in different fields. And every day at 8 p.m., one of our V chairpersons presents to you one stalwart. And today I have with me one such expert and a expert in fetal medicine, Professor Leona Poon from Hong Kong. Thank you, Dr. Poon, for accepting this invitation.
Thank you for inviting me. It's a pleasure to be here.
Thank you. Before we start the podcast, it is my honor and privilege to introduce Dr. Sunita Tandulwadkar, who actually needs no introduction. But I must say she has been the brainchild behind this podcast series and a motivation and inspiration for a multitude of projects which he has started this year. And I must take this opportunity to congratulate you personally and from all of us on receiving the fellowship from the College of Obstetricians and Gynecologists honoris causa recently. He also has received a lot of national awards and recognition for her various projects that she has come through. And one such project is called Sampurna, which means complete holistic approach to a woman, which focuses on preconception care, which is which plays a pivotal role in progressing the wealth of our women of our country. Besides this, she has her projects of Arogya Yog Yatra, which is a spiritual yatra, Do TKs in the Gike, which is a major drive across the country against HPV vaccination. And as I said, these projects as well. So thank you, madam. She is currently the president of Fogsi. She's the president-elect of ISAR, which is the Indian Society of Assisted Reproduction. And she's the founder president of the Society of Ovarian Regeneration. Thank you, madam, for all your projects and for making us part of your wonderful journey so far. And thank you once again. We want you to welcome this podcast with your few words.
Thank you. Thank you, Sita, for your kind and generous use of words. And I'm so thankful. The president can perform only because they have such a wonderful chairpersons. They are the state or cabinet ministers. Professor Leona, Sita is one of our chairperson, expert in a fetal medicine, amazingly talented, creative, passionate, very hardworking and sincere. And most important thing, when you work in the organization, you need a quality that dependable. And Sita is dependable. With her academic knowledge, of course, it becomes an asset to us. And all the podcasts she has taken. So the podcasts are 30 chairpersons on 30 days. They take the leaders from different fields, from national or a global platform. Not necessarily the academic. They can have a philosophical, political, spiritual, any background, who can be the world leader doing a very good work. But I have seen Sita always taking academicians from a fetal medicine from different parts of the world and India as well. And all the podcasts were so educative and so informative. So if I collect her 12 months, 12 podcasts, probably it will become a fetal medicine, one of the e-learning course. And I'm thinking about that because we have such a beautiful educational material. So I'm going to sit with my all chairpersons, what they have done and what we can do with their modules, because this is a beautiful, intelligent property of Fogsi, which they have created in 1 year. So I congratulate you. I also join every day at 8 p.m. just to give honor to the people who are taking out time for Fogsi. I'm so thankful for this celebration, Leona. And definitely, we not only welcome you on a Fogsi platform, but I think you are a global leader. And this podcast will be heard and will be projected all across. We'll give you the link of that, and I'm very sure Sita will send you the link which you can project it on your friend circles, and it will be a great academic phase to everyone who can listen to it. On behalf of Foxy, I joined just to show my honor, respect to you for taking out your valuable time. Foxy always loves the people who work for their organization. Thank you.
Thank you so much for your kind words. And
Thank you.
also to Dr. Sita for creating this podcast. And obviously she's worked very hard in preparation for this. Thank you.
And Leona, our pattern is only
Yeah,
two of you will be in the fray, and I'll be joining the viewers link, and I will be listening to both of you. So thank you. Looking forward to see you in person sometimes. And goodbye today.
We'll all be together and we'll see each other.
In Figo,
Yes.
we probably in that crowd if we can make out.
We'll wait from afar.
Thank you.
Yeah, thank
See
you.
you.
See
See you
you.
in Cape Town.
Bye.
See you. Thank you so much. Thank you for joining. So it's my honor and privilege to now introduce another global leader in the world of fetal medicine and obstetrics. It's Professor Leona Poon. She's the Professor, Clinical Department of Obstetrics and Gynecology, the Chinese University of Hong Kong, and also the visiting professor at the Department of Women and Children's Health, King's College London, the United Kingdom. She's the visiting professor at the Tsinghua Hospital affiliated to Shanghai Jiaotong University, School of Medicine, China, and the guest professor of School of Obstetrics and Gynecology, also the School of Medicine, Zhejiang University, China. She's chair of the FIGO Committee on the Impact of Pregnancy on Long-Term Health and the deputy chairman of the Chinese Academy of Maternal Fetal Medicine, founding board member of the International Foundation for Maternal, Periconceptional and Perineonatal Medicine, Deputy Editor-in-Chief of the Maternal Fetal Medicine, editor of our very popular and very famous Ultrasound and Obstetrics and Gynecology, Chief Executive Officer of the Pregnascence Company Limited, and co-founder and co-director of the Fetal Medicine Foundation Asia Pacific. Importantly, she's an academic specialist in maternal fetal medicine who has dedicated to improving maternal and fetal health. Under the mentorship of her leader or her teacher, Professor Kypris Nicolaides, our father of fetal medicine, she has achieved a wealth of clinical and research achievements, including more than 300 publications. That is huge. In high-impact international journals with an H index of 71, which is also very huge, and has made outstanding contributions to the improvement of clinical standards in the field of maternal and fetal medicine. Professor Poon's work in large pregnancy-related cohort studies and in identifying ultrasound and biochemical markers for prediction and prevention of preeclampsia has been published in journals such as the New England Journal of Medicine, American Journal of Obs and Gynae, and the Journal of Ultrasound and Obstetrics and Gynecology. Briefly, if I might say, we all know that in 2013, the very famous randomized trial, ASPRE trial, Professor Poon had led this across 7 countries in Europe, which was funded by a major grant from the European Union's 7th Framework Program, in which she served as the co-chief investigator. We all know about the ASPRE trial and what impact it has made and she has led the writing of important guidelines which has served as a benchmark for all of us on screening of and prevention of preeclampsia. In recent years, Professor Poon has successfully established a metabolic clock of gestation using metabolics data from the ASPRE trial. This is very interesting, Dr. Poon, and I would like to hear more about it at the podcast. She's currently the project leader of the 2021 National Key R&D Program, Reproductive Health and Women's and Children's Health Protection. And this is basically a development of a suitable drug delivery system to explore the prospects of new use of old drugs for prevention and treatment of PE. That's also very interesting. She has made significant academic attainments and, as I said, has won a lot of awards and she has a lot of notable publications to her credit. She has devoted her her career to improving maternal and fetal health, and her prime goal for the next 10 years is to continue doing so to improve maternal and fetal health through clinical research, very important research, health education, and education. So thank you once again. With an impressive CV like that, I'm honored and privileged to have you once again in our podcast. Thank you so much.
Thank you, Dr. Sita. I want to hide. I can't believe you read the whole thing.
No, almost. I didn't read the whole thing, but almost. But there were so many important things to tell people. I couldn't miss those. So we'll start our podcast. And I know you have such major work. As I said, before we start, I was interestingly wanted to know more about your metabolic clock of gestation, because India, we are going through a metabolic syndrome where every second woman is affected by hypertension or diabetes, and we are just not able to cope. So I just want to know more about this project of yours, if we can start on that note.
So basically, it's slightly different from metabolic diseases. Metabolic clock is in relation to using metabolomics, so looking at metabolite levels in the maternal plasma for predicting gestational age. And through this work, we've demonstrated that through taking aspirin amongst high-risk women, these cases have slowing down of placental aging by about 1.2 weeks, suggesting that perhaps the use of aspirin can delay the onset of preeclampsia and therefore the timing of birth. And of course, as a result, then we can reduce the incidence of preterm preeclampsia. Many people are interested to know how aspirin can prevent preeclampsia. And so far, we're still guessing. And then, so I was talking to my scientists, and they proposed the use of metabolomics analysis to see whether we can understand at the metabolites level that perhaps aspirin can prevent preeclampsia through this approach. So this is how we discover the metabolic clock of gestation. And then we found that the metabolic clock of gestation is quite accurate in predicting gestational age, and then comparing aspirin versus placebo groups. And we saw that there was a difference of 1.2 weeks between the aspirin placebo group and with the aspirin group, with a later gestational age time point by mid-gestation. So this is how we came up with the idea that aspirin can potentially delay placental aging, which is implicated as one of the mechanisms for the development of preeclampsia.
That's interesting. We'll watch the space for more of it to come, and it'll be maybe eventually we can use it for predicting other metabolic diseases as well. So that's because genetics and genomics is all over the place now. So that could be very interesting.
Yes. I think multi-omics is quite an interest right now. Yes,
absolutely. So when we talk about preeclampsia, I mean, we are seeing it day in and day out. What is the scene in other parts of Asia, especially in your part of the world? I mean, Southeast Asia is generally known as a big risk factor. So we just want to know your experience in your side of the country.
So in Hong Kong is not as prevalent. The incidence is about 1.5%. However, Asia is so diverse. And I've seen, some countries having an incidence of 8%. And in China, it's also very diverse, ranging from 2% to about 10%. So I think the burden of the disease or the disorder, so to speak, preeclampsia isn't exactly a disease, is like a spectrum of symptoms. And so I think the burden is significant. And it boils down to the fact that we don't have a good system for screening, thereby allowing us to provide aspirin prophylaxis amongst the high-risk women. So much work needs to be done for us to implement the first trimester screening strategy across the whole region.
Absolutely. So we are also facing the same issues in adopting this whole strategy because there's so much of variability, the urban, the rural areas, the accessibility has we come along. We'll talk about it, the high income. But, generally we see all the other Southeast Asian as not very obese. They are very slim and trim. So, and especially in our part of the country, the obesity factor, BMI factor is a big, big issue which we have to deal with. So do you think that makes an effect as well? This just came out of my mind because, looking at you, I know you've been the same for so many years, but in India, we are faced with so much of a problem of obesity. Do you think, how does that affect, the increased risk of preeclampsia in the Chinese women or the other South Asian women compared to Indian women?
So, yeah, I think body weight matters, and obesity is only one of a number of risk factors for preeclampsia. So I think while we are focusing on obesity causing a number of chronic diseases as well as being a risk factor for preeclampsia, I think what we need to also acknowledge is the number of risk factors that could be equally or at different weight contributing to the development of preeclampsia. And therefore, I strongly advise the use of our combined test, which is an algorithm that has combined a number of risk factors and treating numerical variables such as weight and height and age as numerical variables, and then combining the maternal factors with a number of biomarkers, blood pressure, uterine artery Doppler, and placental growth factor to generate the posterior risk, giving a personalized risk to every woman. And I think this approach is for me a much better approach than going through a checklist of risk factors, because with a checklist of risk factors, then you basically only account for the positive risk factor and you don't account for the absence of a risk factor. And then you also don't account the numerical variables as they are. Right now, the NICE guidelines, we need to dichotomize maternal age. Okay, if you're 40 and above, I joke about this a lot. Let's say I'm 39 today and tomorrow I'm 40. So today I'm still low risk and tomorrow I'll be high risk. I think this, for me, is a perfect example as to why we mustn't dichotomize numerical variables. Because I think numerical variables are very powerful in terms of being used as a predictor for a certain disease. Then I think we need to really use numericals as they are. Combining these factors with biomarkers will generate a personalized risk for every pregnant woman. And I think every pregnant woman deserves to be told her personalized risk for developing a condition. And this approach would certainly increase compliance with aspirin prophylaxis. We all know that pregnant women don't want to take any drugs during pregnancy. And unless you really tell her that her risk is 1 in 2, her risk is 1 in 10, she's like, I'm not going to be the person affected by this. Oh, it'll be someone else. Yeah. Do you follow me? So this is why I'm a strong advocate for offering the first trimester combined test, giving personalized risk to every woman, and that will certainly lead to high uptake of aspirin prophylaxis in preventing preeclampsia.
True, because even in our country, as you rightly said, shouldn't we go by specific factors or risk factors? Take it as combined, because the minute a person walks in, she might be thin, she might be obese. You have to look at the entire picture. And it's an interesting tale of two syndromes or diseases where most of the focus is for Down syndrome screening, which is also equally important. But the more prevalent is preeclampsia, which they forget.
Yes.
And the lady has herself had the disease earlier and she's gone through it, that doesn't come up. But because as a primary method of screening, I think personally, I feel this should come first rather than Down syndrome, isn't it? What is your feeling on that?
I think both mother and baby are important. So what we should be advocating for is mother-baby screening, mother-baby health, and therefore, they come as a package. We can't separate the baby from the mother. We can't separate the mother from the baby. So the way forward is to tell them that at 11, 13 weeks, you receive screening for both yourself as well as your baby. That's great, isn't it? And then I think that would certainly increase uptake for screening.
Absolutely, because if it takes as a combined thing, then the acceptability and the availability also improves and it becomes more cost effective. So we put it as a package and not individualize it. So
Correct.
as you said, we rely on this first trimester combined screening, which you have developed the model, and I think the model is working beautifully. But what are the barriers we are facing to universal screening? Because it is still, I mean, though as whenever we go, as you know, as giving talks and wherever we go, we
Yes.
strongly advocate, but there is still a lot of barriers. And what is your opinion on that? Do you face this same in your as well?
I mean, I think you're absolutely right. You're spot on with our challenges. However, I want to emphasize that universal screening for preeclampsia is extremely powerful. I know someone would have proposed, okay, let's just screen nullips. Forget about multips, unless they've had preeclampsia before, that's a different discussion. Let's focus on the multips. Having not had preeclampsia before. I mean, the thing is, just focusing on the nullips because they've never had a baby before, and then therefore we have no idea about the risk. But the challenge that I have is that, okay, if we start kind of grouping women into different into different programs, and it's going to be very confusing for providing pragmatic screening. And also another point is that, okay, a multiple could have had a long interpregnancy interval of more than 10 years. Just because she had a very healthy pregnancy 10 years ago, it doesn't mean that she's now 40 with a BMI of 40. So, and then she'll completely drop out of your screening program if our focus is only on nulliparous women. So yes, I think I would really strongly advocate for universal screening, making first trimester screening available to every pregnant woman. The challenges, I think, of course, cost is a major barrier, especially in low resource settings, and cost of PLGF, especially, and in some settings, even the scan itself is challenging. I think it's not a problem for you in India, but then I think in other places, then the scan may not be widely available. And setting up the infrastructure for early screening and allowing access to biomarkers like PLGF can be challenging in some parts of the world, whereas I think I'm lucky. In Hong Kong, we have a well-established Down syndrome screening program, and therefore it was easy for me to latch onto that program and add on preeclampsia screening. And through my research in Asia, I've also identified centers like mine, and therefore, yes, our research projects have been very successful, and we've been doing research with collaborators with a similar setting. But then I think we need to now try our best to reach out to places whereby there is no first trimester Down syndrome screening in place, and let's see how we can actually make it happen for us to provide first trimester combined screening for preeclampsia. I think, yes, cost, infrastructure building, and training. Some people are very reluctant to learn something new, and when it comes to uterine artery Doppler measurement, in my practice, it takes no more than 1 minute, but then ultimately I would say you need to factor in about 2 to 5 minutes, and there's a process of training. And then obviously through the Fetal Medicine Foundation, we have a process of certification. You go through the course online, you submit your pictures, and of course you are very welcome to identify training centers like mine and all my collaborators in Asia. And I'm sure there are many doctors in India who are capable of doing uterine artery Doppler, and I do hope that they will join me in providing training for any comers wanting to provide first trimester combined screening for preeclampsia. So step by step. And then the last step would be really going to the policymakers, because they need to agree to widespread universal screening, and I think we can't do it without policymakers being involved. And so step by step, yes, dealing with the nitty-gritty setting up of the screening program, making sure that there are guidelines to follow, and then demonstrating the benefits of the screening strategy, et cetera, and engaging with policymakers, and hopefully maybe in some parts of the world whereby we have some patient groups who will be demanding for better care, that might also put pressure on the system. So many things to consider. Yeah.
Yeah. Lots of things. But even in India, there is so much of variability. Like where I practice in the cities, maybe it's available in some of the corporate hospitals, this facility is available, infrastructure is there. But when you go down to the interiors of the country, there's only a basic blood pressure measurement that's done possibly by the ASHA workers that we call, and they don't have access to ultrasound, the infrastructure. So there's a lot of variability in how we practice in India, and we have a long way to go before we implement this universal screening. Yeah.
But then, okay, but let's not underestimate the importance of blood pressure. So through our FIGO work, our first semester guidelines for preeclampsia screening, our pragmatic recommendation is that the first line test should be a combination of maternal factors with the measurement of blood pressure. Because right now, the NICE guidelines are not even recommending the inclusion of blood pressure. So, the addition of blood pressure can add on 10% detection rate already. So it's a no-brainer for us to incorporate a very simple measurement of blood pressure. And then if it's possible, then you can work your way up and add on PLGF. If the woman has already had PAPE as part of Down syndrome screening, okay, add it on. However, of course, if you have a triple test, blood pressure, usual nostril Doppler, and PAPE, then unfortunately PAPE doesn't add very much. However, adding PAPE onto blood pressure and maternal factors, then you gain another 3 to 5% of detection rate.
That's
ultimately, it's step by step, and I appreciate that. While I'm advocating for what I call the Mercedes test, we may have to settle with a Fiat test to start with, and then kind of generate data and give convincing arguments so that we have more buy-in for the Mercedes test.
Right, that's interesting. So how do we propose to bridge this or build this awareness gaps that are there in the healthcare providers and the pregnant women? Because even in our country, we are trying to make the healthcare providers be aware that please they are doing the Down syndrome screening with the PAPE, but just adding the PLG, just one important, which is not really increasing the cost. So how do you have any suggestions on how we can improve in our setup these health gaps that are there?
Oh, that's challenging too. I mean, even in my setting, I've had women coming to me for preeclampsia screening, and then they go to the private OB doctors, and then they come back and say, oh, my doctor hasn't advised me on aspirin, and is obviously fascinating, and you just don't know what to do in that context, right? So I completely agree with you that awareness gaps remain a major challenge, and till now many healthcare providers may not be fully updated on the latest screening guidelines, and let alone pregnant women, because they may not have access to the latest evidence. And so I think there's no other way of addressing this awareness gap other than to provide more information, provide more education, engaging with patient groups as well as our fellow colleagues who are not directly working with us. So at least in my setting, I run a yearly workshop on preeclampsia screening, and I make that available online as well. But I'm only one person. I do hope that there are more and more people willing to join in and provide more education that is widely accessible to all parties. So don't want to advertise. However, we are running an ISWalk webinar next week on the 1st of October. And Daniel Ronick and I will be co-chairing, and Professor Nicolaides will be joining us. And then we'll be touching on, obviously, various aspects of preeclampsia screening. And I'll specifically touch on the impact of preeclampsia on the heart from the perspective that we have data up to 1 year postpartum, and we're not seeing an improvement in the cardiovascular impairment that we observe as a result of preeclampsia. So, the traditional thinking is that everything normalizes by 6 weeks postpartum, yes, but we're not seeing that now. We are seeing that we might start seeing resolution of cardiac impairment by 1 year postpartum, and that is quite shocking for me. Yes, do join our webinar next week.
Yeah, we always look for webinars, but it's interesting how this goes on to having the non-communicable diseases for these women later in life, and this is the point where we can pick them up, make them lifestyle modifications and prevent them, because as you said, the remodeling that goes through in pregnancy, that has a major impact for all their lives, isn't it? And it's important where all our professionals speak the same language, because when we say something and when they go out into the community and somebody says else, the pregnant woman gets totally confused as to what to do. So I think it's important that we make all our professionals aware, and then we all speak the same language. Yeah. And what about point of care testing for biomarkers? How are they available in very freely? We've just started with it, but I wanted to know your experiences with it.
So right now in Hong Kong, and we're not using the point of care testing of POJ and SLIT1 as short-term predictors of preeclampsia. Sadly, we're not there yet in Hong Kong, but I know that in the UK, POGF is recommended as a point of care test, and I think it's interesting how there is even more resistance to that than first trimester screening. This is what I'm observing. And I think it's about the fact that the tests are not so affordable yet. From our perspective, point of care tests are more expensive than a laboratory analyzed test. And then the reason why it's not happening in my unit is that I have yet to convince the main laboratory in my hospital to roll this test out. And then if I were to rely on my research laboratory, then I can't do it at night. I can't do it on Saturday and Sunday. And then, of course, then that's not clinically useful. So, but I'm actually looking into a urine test. And I've been looking at that for some time already. I looked at the Congo Red in collaboration with a company in China. Of course, the thought of using a urine-based test is appealing because it's simple. Results will be available in 10 minutes, affordable, and then you can triage women with suspected preeclampsia into home care or inpatient management. And I think the idea is definitely very appealing. And now we are about to investigate the second version of the test, because the first version of the Congo Red test isn't so sensitive, but it's very specific for preeclampsia. And I hope that such point of care test would be clinically useful in the sense that it's effective in really identify women who will subsequently develop preeclampsia, and then they would receive the appropriate care. And then the majority of these women with suspected preeclampsia will be able to go home, and obviously from a health economics perspective, that could be very cost effective. But at the same time, then we can focus on inpatient management on those who truly need our attention. Yes, I hope that with our next project, we'll be able to demonstrate that the urine test will be a very, very effective point of care test for triaging patients with suspected preeclampsia.
That's fantastic. On the same note, how has your experience been with the SLIT-PLGF ratio for prediction of late preeclampsia? Because the FMF test is more for early, isn't it? What has your experience been with that? Because we've started using it and we are seeing very good results of using. Of course, it is still the cost is a factor, but people who generally need it, I think in the long run, if you need unnecessary admitting these patients, or we can be like, as we say, it's the negative predictive value is very good. So what has been your experience with that?
So I'm sure we've all heard from Professor Nicolaides that he's completed his trial, the PREVENT trial, and at 35 weeks, combined screening using SLIT-PLGF amongst asymptomatic women. This approach is effective in identifying women at risk of term preeclampsia, and then these high-risk women are triaged into different timing of induction labor. And for in our practice, so through his trial, he has demonstrated that such an approach can reduce the risk of term preeclampsia by 30%, which is, very, very impactful. We haven't done such a trial in Hong Kong. However, we are looking at we haven't analyzed data yet, but certainly we'll be looking into our PLGF SFIT data measured at 35 to 37 weeks in predicting term preeclampsia once I've completed my study, because that is ongoing right now. So it's a research project.
Okay. Right. And the same goes for ophthalmic artery Dopplers as well, isn't it?
Correct. Yes. Some of you might have heard me speak about uterine artery Doppler being less useful in Asian women, and that certainly we're wondering whether the ophthalmic artery Doppler could replace the measurement of uterine artery Doppler. That is work in progress. Thank you.
Yeah, we're waiting for all this. That will serve so much. I mean, it'll make it easier, because I think it's much easier to do those as well. But and we can use it for all trimesters, isn't it? Very effectively.
Correct.
That'd be good. Just let me know. And then coming to basics about the stigma that is going around this community aware campaigns and the common myths that are there. We need to sort of, get rid of them and train these midwives. Some points on that, if you would like to note on, because there's still so much of negative sort of feeling when
Yes.
we're saying, especially when we talk about screening. So, yeah, I just want you to your comments on that, please. Yeah.
So I can't agree more. Stigma and myths around pregnancy complications, such as preeclampsia and even pregnancy loss, remain widespread in many communities. And these misconceptions can delay care and isolate women. And then, sometimes I see these women come to our clinics, and then it feels like they can't speak for themselves and they don't have a voice. It is very challenging to overcome cultural barriers and the involvement of family members in the care of a pregnant woman. And I think I don't have any perfect solutions. I don't have any magic solutions. And certainly, just as I said earlier, reducing the awareness gaps, I think, we need to do it through education. I think, addressing these challenges, we can only try our best. And if there's a possibility of developing community awareness campaigns, so educating women. So lately, I'm talking about educating family members as well, because as I mentioned, we're doing a lot of work in the postnatal period now, and then we touch on nutritional health, physical health, and then we're like, oh, maybe if I teach the woman, isn't actually sufficient. We probably need to teach the whole family. Because teaching the mother-in-law, what kind of food she needs, because we tell these women they should eat X, Y, and Z, and then when she goes home, she expects something completely different. So I think we have some of the problems. The Indian culture, the Chinese culture are very, very strong, and then. For us, we have a confinement month. After 1 month, within the 1 month after the birth, our postnatal women eat very unhealthy food. They're not meant to wash, but of course nowadays it's not possible not to wash. But then in the old days they didn't wash, and so we need to change the mindset of everybody, not just the pregnant women and the postnatal women. We need to provide family-based education so that everybody is on the same page, and therefore the whole family can improve their health altogether. If you know what I mean. So I think because everyone's obsessed about the baby, and they should because that's our future. But at the same time, if you think about the woman, she's only 20 something, 30 something. She still have her whole life ahead of her. And I think we can do something very positive to also improve her inter-pregnancy health, long-term health as a result, and obviously improving her next pregnancy health as well. So there's so much that we need to do, and I'm thinking, yeah, we need to do family education. And that will really be helpful to all the pregnant women and postnatal women.
Yeah, that's a very important point you've touched upon about family education. That's so important because we tend to sort of believe that what we tell her will be the same thing that she'll practice at home. But 9 out of 10 that doesn't happen. And you rightly said, we also have our myths in the first 1 month of life. They are fed a lot of sort of fat food to get breast
Same.
milk and stuff, which actually makes it worse. It worsens
Correct.
their that they
Clock. Yeah,
because
all the
not
ducks are clocked up. Yes. with with
very true. That's so true. But at the extreme, I would just like your comments on that. At the extreme end of the other end of the spectrum, we have these women who are, especially the ART pregnancies, who are given a lot of these cocktails and mocktails
yeah.
with
Oh yeah.
aspirin loaded as well.
Yeah.
Then even if, yes, they are at high risk, but it's so important to get them off a medicine which they actually
Yeah.
don't need. And
Correct.
it's so
That's extremely important as well. I think
yeah.
we face that a lot in our community, and often the woman comes with a list of 20 drugs, and the best thing we can do is go through one by one and explain the lack of evidence for each. And of course, I can't force a woman to stop everything, but it's a matter of negotiation and meeting each other halfway. And then we can try, okay, you can
Yeah.
take this off for now. And then, okay, happy for you to go back to your, um, um, IVF doctor to ask for more advice. So it's a matter of building a rapport, building trust, and
Yes.
not attacking the IVF doctor as well,
No,
because I think that doesn't help.
yeah,
It doesn't
true.
help.
No,
I
it's the
mean,
fear
because
factor. It is the fear factor that these women have because they've had gone through so much to have this pregnancy. And so it's important. So deep inside, though they might not want to take the medicine,
yeah,
but just the
yeah,
fear of losing pregnancy
yeah,
and all that.
yeah,
So it's so
correct.
much for them at stake. So they
Yeah.
can't take, they don't want to take a chance. And it's obviously fair on their part when they think in that way. But yeah, towards the end of it, I'd just like to ask you, everything is so AI driven now, healthcare itself, imaging, even I'm soon told that, you will not be needed. AI will take over, but I'm happy in obstetrics where at least delivery births will not be taken over by AI. But how can AI help us in low cost digital screening tools? I mean, how is that helping us now? And what is the way forward?
I think AI has a huge potential in healthcare provision, and certainly when it comes to screening, yeah, we are seeing AI based models being developed, and I think ultimately it will be an ideal situation whereby everybody has access to screening, even in the rural areas. And at some point, I'm sure everybody has a mobile phone. There'll be a way for pregnant women to key in their risk factors and to get a baseline risk generated. And then perhaps that would allow certain, well, women with intermediate risks and high risks to go in for secondary screening, etc. So I think ultimately, yeah, model development is going to be very useful because AI could incorporate data from all over, and then I dream that there'll be a unified prediction model for everybody across the globe. And then maybe the next phase is management algorithms, right? Well, of course, we need a huge amount of data for generating management algorithms and giving guidance, and then now there's all these chatbots, so
Yeah.
it'll be easy for answering some questions. I was in a hospital in China, visiting a hospital in China, and then I was told that they have a chatbot for dealing with at least 120 scenarios already. So going forward, yeah, screening can be done remotely, and then some women will need to go in for additional testing, and then chatbot could allow for some basic communications before the women go in for second-tier screening and before the woman gets her aspirin prophylaxis. And then be very, very useful in countries like India and China because our countries are very, very big. And then access to care is variable in different parts of the country. And, in China, we have a 5-tier system and can only imagine that a tier 5 city. So the level of care will not be as good as a tier 1. And then I do hope that there's a chance of equitable care. So the same screening algorithm that is available in a tier 1 city will also be available in tier 5 city. And then AI could potentially bridge that by providing a way for these women to communicate with the chatbot for very basic concerns, and then that will guide them into receiving a clinical care or a hospital care, so to speak. So I don't know. It will be very interesting to watch the space as to how AI will transform healthcare. But then you're absolutely right. We still have a job. I don't think there are robots there yet to catch a baby, but you never know, I saw that someone has built a robot to carry a pregnancy from
I saw that too,
conception to full term. So I don't know how true that is, and I haven't seen research data. I haven't seen anything, so I don't know how true that is. I don't know how feasible that is.
Yeah.
And then, of course, other consideration will be ethical concerns and quite shocking, to be honest. But then we'll definitely watch this space. And I would say that as an academic, my role is to be the goalkeeper. There are amazing technologies coming our way, just like cell-free DNA testing, right? All these companies have these fantastic tests, and pregnant women only know these tests as the perfect, magical test. Oh, my baby's okay, but that's not true. And so it's really up to us to kind of validate the test, generate high quality data to inform clinical practice. And I think that is exactly the same for AI healthcare. Everything that we do, there must be a process of clinical evaluation, clinical validation, and ensuring that whatever we do new is beneficial for the patients, that we are going to improve outcomes and not causing harm. So I'm not skeptical, but I think I have a role in ensuring safe delivery of care and making sure that all these fancy things are really leading to better outcomes for our patients.
Fantastic. Yeah, that's a very, very important point you've said, and very important role of we clinicians we have here, not to completely rely on this AI without understanding the evidence. So thank you, Dr. Pone. I mean, it was wonderful. I hope I've not taken much of your time, but I just need some sort of parting words from you before we close this beautiful session we've had on preeclampsia screening, especially the Asian perspective. Some parting words from you before we close.
I hope you don't mind me saying it over and over again. It's the same story that I tell. Of course, we need to advocate for universal screening for preeclampsia, and I hope that we've done enough to demonstrate to you that the first trimester triple test, including maternal factors and blood pressure, uterine artery Doppler, and placenta growth factor, is currently the best test available. Of course, I would not say no to other tests if they are equally good, and so we need to provide screening and then allowing high-risk women to receive aspirin prophylaxis, which is obviously proven to be effective in reducing the rate of preterm preeclampsia. So hopefully more of you would agree with me, and then that you would continue fighting for better care for our pregnant women. Thank you.
Thank you. Thank you. I think, and that will go a long way in reducing our goals of reducing the maternal mortality to 2 figures, which we are going in the right direction, but I think more needs to be done. Thank you so much, Dr. Poon, for sparing your valuable time and giving us this wonderful information on this beautiful podcast. I'm really watching the space for some more extraordinary research work coming from your end about the other predictors. As you've said, you're working on them. So looking forward to those. And thank you once again. Have a good day. Thank you.
Thank you, Dr. Sita.
Thank